Good afternoon, everybody. Thank you for attending the current webinar, and thank you for taking us through, ma'am, about the basics of fecal calprotectin. And I'll be dealing today with the role of fecal calprotectin in clinical aspects. So, whenever we talk about fecal calprotectin or any, for in that case, any stool reports, there is reluctance from the doctors, maybe pathologists or the clinicians, or the reluctance of the patients on getting it done. But I think by the end of this talk, I think everybody attending this seminar would be in favor of utilizing fecal calprotectin to its full potential. So when we see a patient who comes to our clinic with abdominal pain, abdominal discomfort, diarrhea and constipation, the question that we ask ourselves is it irritable bowel syndrome or is it inflammatory bowel disease? Now, for all the non-gastroenterologists, I'll take you through it that IBS and IBD, although they sound so similar, they are completely separate disease. IBD consists of Crohn's disease and ulcerative colitis, and IBS consists of irritable bowel syndrome. The management of IBS on one side is symptomatic, where we treat abdominal pain, constipation, diarrhea based on the patient's symptom. And when the patient gets diagnosed with inflammatory bowel disease, we treat with mesalamine, steroids, immunosuppressions, biologics, and sometimes they even need surgery. There are clinical markers which favor the presence of IBD over an irritable bowel syndrome, but they are not foolproof, and sometimes we most of the time end up getting them investigated. So the routine investigation that we advise is CBC, ESR, CRP, and a stool routine micro. And once we suspect them to have an IBD, we undertake a colonoscopy or a sigmoidoscopy, which is a gold standard for diagnosis. These are certain images of the colonoscopy that we see in IBD patients, but it is invasive, unpleasant, needs sedation, and it has its own complication. And when we carry out such procedures in young individuals, there are 60% of these procedures turn out to have completely normal colonoscopies. So what we do require in these patients is a simple, rapid, sensitive, specific, inexpensive and a non-invasive test to tell us whether it is an IBS or IBD, as well as one which guide us in the management of IBD without need of repeated colonoscopies. So the question that I'll be answering today is fecal calprotectin the answer to this requisite? Now, when we talk about fecal calprotectin, we need to know the ideal way to collect a sample. So it should be ideally collected at home. There should be at least 100 mg of feces collected. Normally, normal feces should be collected. No contamination should be there, and the first morning sample is preferred. There is a lot of variation in the values when we are collected in different parts of the day, and the sample should be assessed and evaluated within 3 days. Now, when we look at different studies, in the healthy individuals, this is highlighted. The level of calprotectin is quite low. It is 30, 26, 10, and in that level. So if we see the data from the recent publication based on the age, so up to 4 years it may be above 50, a normal range, when up to 18 months it is quite high, that is 174, but beyond 4 years I think the normal range remains quite low. So less than 50 microgram of calprotectin per gram of stool is considered to be normal, while more than 250 is considered to be suspicious of inflammatory bowel disease. 50 to 250 is a gray zone. So this is the basics about fecal calprotectin, and now how do we utilize it in our own practice? So all the clinicians, which may be, even if they are gastroenterologists or non-gastroenterologists, you would come across this kind of patients who will complain of abdominal pain, fever, weight loss, diarrhea, and we need to rule out whether they suffer from inflammatory bowel disease or not. So the first thing that we do is differentiate IBS and IBD. Now IBS, we need to know that 12.1% do have raised fecal calprotectin. However, the levels are not significant and they are never above 250. So a meta-analysis published in 2015 concluded that if the fecal calprotectin is less than 40, it essentially excludes IBD. Recently published publication, if we see, they have looked at they've utilized the clinical presentation and then stratified the utility of fecal calprotectin. So they divided symptoms as major and minor criteria. So a person having even a single major or two minor criteria, they should be considered for fecal calprotectin evaluation, which may be a diarrhea persistent over 2 months with nocturnal frequency, presence of blood in or complaint of blood in stools. If there is abdominal pain with diarrhea, that is painful diarrhea, weight loss, recurrent pyrexia, history of any perianal fistula or abscess or perianal lesions, anemia, or a family history of IBD, they are considered to be minor criteria. They should undergo fecal calprotectin level, and a threshold or a cutoff that they have selected is 70 microgram. The diagnostic accuracy is 70.6%. However, I will say that the negative predictive value was 96.2%. So if you select these patients and their fecal calprotectin is less than 70, there is 96% probability that the person is unlikely to have IBD, and this is the diagrammatic representation of the same phenomenon. If you look at the symptoms, patient complaining of altered bowel habits, and then if we see the role of fecal calprotectin and divide them according to the age. See, in the age of 18 to 39 years, the sensitivity of fecal calprotectin is 100%, but as the age goes up, the sensitivity of fecal calprotectin goes down. If we look at the overall data, the sensitivity and specificity is quite good. And in a recently published literature, if we see, the sample size of patients was nearly 6,000 patients, had a sensitivity of 95% and a specificity of 91% in diagnosing inflammatory bowel disease, or helping us come to a conclusion. So if we see that if we use fecal calprotectin as a screening modality, there may be 2/3 in the number of colonoscopies was reduced by 2/3, but at the cost of missing 6% of patients with IBD. So whenever a person comes to you with pain, diarrhea, fever, or weight loss, we get a fecal calprotectin done. If it is less than 50, we can safely assume it to be an irritable bowel syndrome. If it is more than 200, we label it as highly suspicious of inflammatory bowel disease. 50 to 200 is low inflammatory activity, and that needs it's again a gray zone. So once we know how to differentiate IBS and IBD from fecal calprotectin level, now we'll discuss how in it just beyond screening and labeling patients to be IBD, how it is utilized further. So the next utility is understanding the disease activity of IBD. So a patient with Crohn's disease, if they have a highly inflammatory parameter more than the stricturing and the penetrating phenotype, their fecal calprotectin is to be higher. In ulcerative colitis, again, extensive colitis is likely to have higher fecal calprotectin as compared to a left-sided disease. When we correlate with the disease activity based on endoscopic index of severity, the fecal calprotectin has a linear rise with the rise in the severity of endoscopy score, and you can see the diagram on the right that the two scores nearly correlate with this correlation ratio of R is equal to 0.72. Similar is the picture with the Crohn's disease, where Crohn's colitis and the endoscopic as well as the fecal calprotectin level correlate with each other, and with the increase in histological severity, there is linear rise in the fecal calprotectin level. In this published article, which is where they have seen, because a lot of times gastroenterologists monitor Crohn's disease patients with CBC and CRP, and they don't get a fecal calprotectin level done, and this study clearly tells us that fecal calprotectin is the best modality to assess the disease severity on a follow-up, and not the hemoglobin or platelet or a CRP level. Now once we know that it can be used to assess disease activity, can it be used to understand the site of involvement? So it correlates better with the colonic Crohn's disease rather than ileal disease, and it correlates better with ulcerative colitis than the Crohn's disease. So if there is isolated ileal disease, there are high chance or high likelihood that it may have a false negative results. So looking at this literature, in this with 72 inflammatory bowel disease patients were included, where 23 had colonic Crohn's disease, 14 had isolated small disease. If we see the ROC curve for isolated Crohn's disease, ileal Crohn's disease, you can see the EUROC is just 0.52, and it is not used, while when we use for colonic Crohn's it is quite good, and the AUROC was 0.95. So in a systemic review, if they have seen, there were various studies where they have included 16 studies, and the correlation of fecal calprotectin with the endoscopic level, endoscopic index of severity, as well as an MRI index of severity, was more with the large bowel disease as compared to the small bowel disease. And when they have used various studies, if we see the on the right side, the different cutoffs used by different studies to identify small bowel disease, and as such there is no consensus of utilizing fecal calprotectin to diagnose small bowel Crohn's. However, I like to say that once it is known that you have a small intestinal disease, fecal calprotectin can then be utilized to actually monitor the activity, and there are studies where fecal calprotectin level correlates with the capsule endoscopy findings. So it is more likely Crohn's disease, more likely colonic involvement, and then we come to the response to treatment. So we would like to know, once we start the treatment, what is the likelihood that the patient is responding. Now it is clearly understandable that as the patient starts responding to treatment, the fecal calprotectin is expected to go down at 4 week and 8 week, and there is significant reduction in fecal calprotectin at 4 weeks and 8 weeks in patients with both ulcerative colitis and Crohn's disease. So what they have concluded was a normalized fecal calprotectin concentration at 8 weeks predicted a complete response, and no significant change in fecal calprotectin concentration in patient without endoscopic response. If we look at the importance of this marker, there are two definite indications for using fecal calprotectin. Out of that, one is with monitoring treatment response to biologics or even to tofacitinib in patient with ulcerative colitis without the requirement of endoscopy. So a person whom we are starting infliximab, we can monitor the patient with fecal calprotectin, and we don't need an endoscopy to guide us. Whether once they without responding, it also predicts failure and need for colectomy. So in this study, which is quite old, but in this 90 patients were included, out of which 34% required colectomy. And if they compared at time of admission, the patients having more likelihood of colectomy, corticosteroid non-responders or infliximab non-responders, they had significantly higher level of fecal calprotectin as those compared with responsive disease. Similarly, article published in 2017 where the 49 patients were included, 43% failed to respond to IV steroids in acute or severe ulcerative colitis, and where they concluded that if the fecal calprotectin level at the day 3 of IV steroid is more than 1000, then the chances that the patient is likely to respond are quite low. And you can see this is an Indian study. Now this is one more important study in Crohn's disease, where they have seen whether the patient is likely to respond to infliximab or not. So in 32 Crohn's disease patients, they have actually measured fecal calprotectin at the onset of the disease and at the completion of induction therapy. And if the fall of fecal calprotectin is less than 70% of after the induction, which predicts that there is not response to anti-TNF alpha therapy in these patients. They have also utilized fecal calprotectin to actually monitor vedolizumab therapy, though I have not used vedolizumab in India. But if we can see this study, at 16 weeks they have assessed the response by fecal calprotectin, and if it is less than 200, they say that it is indicative of endoscopic response and there is no endoscopy required. We can continue safely vedolizumab. While if it is more than 450, that means endoscopic response is extremely unlikely and we need to titrate the therapy and no need of an endoscopy is there. However, if at week 16 the fecal calprotectin is between 200 to 450, then endoscopy may be required to assess the response. The similar protocol is followed also at 52 weeks. So at 16 weeks we can assess the change in therapy. Now this is an important trial where they use the the decision making on the basis of clinical improvement, while decision making of intensifying the therapy based on tight control group, where they have not only looked at clinical symptoms but they have also looked at CRP, fecal calprotectin levels, and prednisolone. So once fecal calprotectin levels at the evaluation at 11 week, 23 week or 35 week after randomization was significantly elevated, then they used to upscale the therapy or upgrade the therapy, increase the duration or increase the dose of adalimumab. So it can respond to treatment. It also guides us about the prediction of failure and the need for colectomy. It also predicts remission and mucosal healing rate. So in this study 5 years back, where they have shown that a level of 56 was optimal to predict remission. So if a person with inflammatory bowel disease comes to you on treatment and his fecal calprotectin is less than 56, we can safely assume that this patient is in remission. In the recent literature, where we have seen in patients with Crohn's disease, 268 patients were included, out of which near more than one-fourth had a complete mucosal healing, where they used a cutoff of 81, which showed a sensitivity of 0.6 or specificity of 0.81. But when we added the serum CRP and serum albumin, the AUROC increased to 0.82. In the patient again with the Crohn's disease, where 677 patients were included, at the week or 6 they assessed whether the calprotectin was less than 250 or more than 250. So in patients with less than 250 at 6 weeks, there is 3.48 times more likelihood or odds ratio of having a complete endoscopic remission at 52 weeks. So at 6 weeks we can tell the patient whether they are likely to have a complete endoscopic healing by the end of the year or not. This study where 375 patients were included, where the normalization of fecal calprotectin was monitored over a period of 12 months, and those who had normalized fecal calprotectin levels at 12 months, their survival was significantly better as compared to those who did not have fecal calprotectin normalization. And you can see the monthly monitoring of this patient. Those who had disease progression had significantly elevated fecal calprotectin levels throughout the year, and they didn't normalize at the end of 1 year, while the patients without progression had a normalization of fecal calprotectin. The similar results are reported with ulcerative colitis. In this study, 109 patients, where mucosal healing was seen in 45 patients, a cutoff was used of 157, and if we see at a cutoff of 157, the AUROC turned out to be 0.82. So if a patient with ulcerative colitis achieves fecal calprotectin level of less than 157, there is more likelihood of them developing mucosal healing. Similarly, in this study, they have looked at clinical remission, endoscopic healing, deep remission, histological remission, and complete histological remission with endoscopy plus histological remission, where they have looked, and those people who at 8 weeks and 52 weeks had lower fecal calprotectin level, significantly lower fecal calprotectin level, they were more likely to achieve this remission than those patients having higher calprotectin levels. And if we look at the various cutoffs that have been used, it feels that if the optimum cutoff that we use is 75 and 100 for a person who is on treatment of ulcerative colitis, we can safely assume it to have mucosal healing. Again, in this patient, where they have it in a prospective multi-center study where they used a cutoff of 70, the sensitivity turned out to be 90% in developing mucosal healing. There are different numbers, different studies, and there is no definite number which we should follow. For example, this study where they have used 225 should be a cutoff of Crohn's disease, while 112 and 75 should be considered to be for ulcerative colitis. Now we know about remission and mucosal healing rate. Now it can also predict relapse. So again, this is slightly old study, old meta-analysis, but if we see that in ulcerative colitis, if the fecal calprotectin level was higher than 150, then there was 14-fold higher risk of relapse, and in colonic Crohn's disease with 340, the risk of relapse was more 18-fold if we use this cutoff. Now if we look at this publication just published last month, the different cutoffs have been used to predict relapse in the disease with good sensitivity and with good specific, I would say not very extreme, very good sensitivity, but very good specificity to have a cutoff to predict relapse. Again, in ulcerative colitis as well, if there is a meta-analysis that showed that it has very good sensitivity with a URS pool sensitivity of 0.75 and a pool specificity of 0.77, in predicting clinical relapse are for adult patients with ulcerative colitis who clinically appear to be in remission. After surgery in Crohn's disease, it may also predict recurrence. So more than 80% of Crohn's disease patients require surgery within 10 years of diagnosis. Fecal calprotectin normalize after uncomplicated surgery at 2 months, and a third of patients will have a clinical recurrence. And who would develop recurrence? We can easily understand by fecal calprotectin, and there is enough data to say that enough studies published that it can be utilized. Serial fecal calprotectin levels can be utilized to detect endoscopic recurrence. And what they have found out is that a fecal calprotectin greater than 100 would indicate an endoscopic recurrence, while a less than 50 would indicate an endoscopic remission. Now this is an interesting where they have measured fecal calprotectin after the surgery and at 3 months, and if there is 10% rise of fecal calprotectin level at the end of 3 months, there is very high likelihood that this person is likely to have recurrence at the end of month 6. Coming to the few final slides, and now I'll breeze through the presentation, that is pouchitis. So in this study, actually a systemic clinical review where 7 studies were included with 256 patients of pouch after an IPAA, the ability of fecal calprotectin to detect a pouchitis was with a UROC of 0.8 to 0.84, and so it can be considered as a reliable diagnostic tool for acute pouchitis. Utility in clinical in childhood, I think, as we have already discussed, that in normal healthy children also fecal calprotectin are significantly higher in early age or in infancy and during first 18 months. Now this is a data from nearly 12,000 children where they have seen that median levels are less than 1 would be 50, but they are less than 50 in most of the children above 1 year of age. And with the disease increase in the severity of disease of IBD, their level also increases, but we just need to understand that they might have a cutoff which is slightly higher than the traditional cutoff for adults patient, and so the same cutoffs cannot be used for children. For asymptomatic relative, you come across a patient with IBD, he has a sibling who may have an IBD, you don't need to undertake a colonoscopy to tell them whether he is likely to have a IBD or not. A fecal calprotectin level would guide us for the diagnosis of IBD, which can have a subclinical intestinal inflammation in these patients. Now other utilities. Now, as I said, the fecal calprotectin is not specific for IBD, and there are a lot of other conditions. I think it is easily available on the net, and this is a great article where they have looked at the practical utility of fecal calprotectin, where it may or may not, there are the factors which may or may not increase the fecal calprotectin levels. But this Indian group from northern India have looked at 37 patients who were empirically started in ATT, and whether the suspicion of Crohn's versus tuberculosis was pending, and they have said that it may help, but we need more data to be able to actually utilize this. There are publications where they have shown utility for small intestinal bacterial intestinal overgrowth, systemic sclerosis, cow's milk allergy, colorectal carcinoma, gastric cancer, Clostridium difficile infections, NSAIDs enteropathy, GVHD, necrotizing enterocolitis. I think a lot of publications are there, a lot of data is there for role of fecal calprotectin in pediatric necrotizing enterocolitis. They have also used for extraintestinal disease of primary sclerosing cholangitis, hepatic encephalopathy, as well as spondyloarthritis, where they have looked at the utility of fecal calprotectin. Coming to the end of my talk, I think we are all facing the COVID crisis, and where we all are scared to undertake a colonoscopy as a screening procedure, where fecal calprotectin would be utilized in a better way. And this publication has looked at the non-invasive monitoring of IBD in the post-COVID-19 era. And if we look at this one of the support groups says that if we have a patient with giving a stool sample, and the results are automatically transmitted to the IBD team, where they take a disease and on the basis of the levels of fecal calprotectin, and guide the patient whether they would just need a regular follow-up or an early visit. So to summarize my talk, fecal calprotectin forms an integral part of screening and follow-up of patients of IBD. In the times of COVID-19, I think we should be utilizing it more frequently than relying on patients turning up for the routine screening endoscopies. But when we use this marker, we need to keep in mind that this is not specific for IBD and we should know how to interpret the results. I would thank the institutes where I have worked and thanks my teachers for making me reach where I am today. Thank you.